We are, good evening to one and all. We have gone past like a little bit more than halfway through. We have learned a lot about patient and palliative care. Patient care, nursing care forms a very important element. As we always say, we are a multimodal team. So nursing care forms a very important. There's no palliative care without nursing care. So we are going into another important topic discussion today with the most eminent person who is going to throw light upon that particular topic, who is well recognized for her nursing expertise by obtaining the as known as a pioneer nurse by the St. Christopher Hospice of UK. She's headed the nursing team and part of TIPS Pallium India. And she's worked in the Department of Regional Cancer Center, Trivandrum. And she strives hard to obtain maximum success in her profession. Over to you, Sister Sheeba, for enlightening us today.
Thank you, ma'am, for the kind introduction. Good evening, all of you. Nice to see you all. As ma'am said, today we are going to learn about one of the major nursing issues, wound management. So you might have seen different types of wounds in your settings, but in palliative care, we have seen two different types of, mostly we have seen two different types of wounds. One is pressure ulcer, bed sore, and the another one is cancer or fungating. So let me share my screen first. I hope my screen is visible to everyone.
Yes, yes, dear.
Thank you, ma'am. So first we are going to learn about pressure ulcer. So there are three major causes of pressure ulcer. So one is unrelieved pressure, and the another one is friction. The third one is moisture. These are the three major causes of pressure ulcer. So what is pressure ulcer? Can anyone say what is pressure ulcer? You can unmute yourself and talk, or you can put your answers in the chat. Ma'am? Your voice is breaking, ma'am.
Can
you put it in the chat box? Okay, thank you. Over bony prominence, especially over the bony prominence. Okay. Any other answers? Due to pressure, due to unrelieved pressure. Okay. Okay. Thank you. Ulcer develop as a result of continuous pressure on the bony prominence. Okay. Thank you for the contributions. Pressure ulcer is a localized injury to the skin and other underlying tissue. So usually over a bony prominence, it's a result of prolonged unrelieved pressure. Okay, so if there is a prolonged unrelieved pressure there is a chance of pressure ulcer over the bony, especially over the bony prominence, but it can occur anywhere. Okay, not only this pressure prominence, but it can occur anywhere, depends upon the patient's position. So coming to the pathophysiology, we have to keep it in mind always. Whenever we have seen a bed-bound patients, you have to tell the caregivers and the patient the importance of the changing of position. So how does how does the pressure sore will develop? This pathophysiology we should understand first. So you can imagine a patient lying on a bed. So if there is a pressure, continuous unrelieved pressure for a long time, because of his body weight and the bone weight, that weight will be compressing the tissues. That tissues, if there is any continuous unrelieved pressure there is the tissues, underlying tissues may not get adequate blood supply. If the tissues may not get adequate blood supply, what happens? So tissue ischemia, stress and breakdown. This is the pathophysiology of pressure ulcer. So that is why we need to change the position every 2 to 3 hours. Otherwise, pressure sore will develop. So let's see what are the risk factors. There are a lot of risk factors. One is friction. The friction is within the hospital, the doctors, nurses are there for take care of the patient, for a bed-bound patient. If there is a bed-bound patient, there definitely our nurse will take care of their nursing care. But when they go back to their home, who will take care of the patient? The caregiver will take care of the patient, right? So for a bed-bound patient, we need to change the sheets every day. What happened? So they don't know how to remove the sheets. They pull the sheets under the patient. There is a chance of friction in between the skin and sheets. So if we demonstrate or educate the caregivers completely, so they should know how to change a bed sheet from a bed-bound patient. That way we can avoid friction. The second thing is shear. Just imagine an obese patient. They usually slipping downwards to the bed. So when we reback to their normal position, what we usually do, we call 1 or 2 assistants and pull them up. So there is a chance of tissue injury, deep tissue injury. So that also we can avoid. And impaired sensory perception and impaired physical mobility. Just for a paraplegic patients was not able to sense the lower part of the body, but they are able to sense their upper part of the body. Here, if they want to change the position, so they know they need to change the position. If they want to change the position, they are not able to they change it independently. They need help always. So these type of patients can develop pressure ulcer. Altered level of consciousness, either semi-conscious or unconscious patients can develop pressure ulcer because is the prolonged unrelieved pressure. Fecal and urinary incontinence. Here, so paraplegic patients also can develop fecal and urinary incontinence. And as I said earlier, moisture is one of the major causes of pressure ulcer. Here, if there is a fecal and urinary incontinence there is a chance of moisture and that patients can get pressure ulcer. And malnutrition and dehydration. So malnutrition is one of the major part, because even if you turn the position every 2 hours early, you provide a mattress, everything for the patients, if there is a lack of nutrition in their diet can cause pressure ulcer. So nutrition is also, the protein intake is also mandatory. And excessive body heat, advanced stage. These are the major risk factors of pressure ulcer. Coming to the common sites, it can occur anywhere, especially on the bony prominence, but it can occur anywhere. Even if the patient is on wheelchair also, the patients can get pressure ulcer. You can see that picture. Even heel, occiput, scapula, toe, sacrum, these are all the areas the patients will develop pressure ulcer. Let's see one by one. In the supine position, this is the most supine position, this is one of the common position. You can just see that images, head, shoulder, elbow, buttock, heel, toes. These are the common sites for a supine position patient. So why I am telling these points is, you have to turn the patient from supine position to side lying position, either right lateral or left lateral position. Even if the patient is on right lateral or left lateral position also, these are the pressure points. So if you turn the patient from one position to another position, you have to look at the pressure points. If there is any color change there, you have to give a special attention on that area. If the patient is on side lying position, in between the knees, there is a chance of the knees are rubbing together and friction is there. So again, the patients can get pressure ulcer in between the knees. When the patient is on the side lying position, you can keep a small pillow or a folded sheet in between the knees, and that way we can prevent friction. So coming to the Fowler's position, this we all know that this is a good position for a breathlessness patient. Even if the patient is on this Fowler's position also, you need to change. At least you need to relieve pressure at least 10 degree. You no need to that put the patient is supine position or side laying position, but at least 10 degrees. Say you can keep the same position, and at least 10 degree you can position change. You can relieve the pressure is mandatory. Coming to the prone position, here you can see that important the major pressure points. This is also if they have a major pressure ulcer on the sacral area, we usually put this position, put the patient is in this position. Before, if they are, if the health state, the patient's health status is okay, before, if we are planning to do the skin graft procedure also, that time, before 2 weeks, we used to keep the patient like this. After the skin grafting procedure, they need to they need to maintain the prone position at least for 3 weeks. So before that also we put the patient in this position. But even if the patient is in prone position also, these are the major pressure points. Coming to the stages of wound, there are 5 stages of wound. The first one is non-blanchable erythema. So this is the first stage. So if you have seen this kind of redness or if there is this the color change there, when you usually when we turn the patient from one position to another position, if you have seen this kind of the color discoloration, so you can apply your finger pressure on that area. So what happened is your usually that red color is blanching, but if there is a stage 1 pressure ulcer, there is not that red color is not blanching. So that is non-blanchable erythema. So if you have seen this kind of stage 1 pressure ulcer, you have to prevent further pressure on that area. Next is stage 2. If you if we are not noticed in the first stage, definitely the skin will break down. The dermis layer will break down, or blister formation will be there. If there is a blister formation there, definitely the skin will break down. So the dermis layer will damage, but there is no pus, no infection, only the clean wound is there. Next is the third stage, full thickness ulcer. You can see that images, full thickness ulcer, all subcutaneous tissues will be involved, and sometimes tunneling will be there. So tunneling is a narrow opening or passageway that can extend in any direction through the soft tissue. So you can see that image. So when we do the assessment on the, of the wound, you have to assess well whether the wound is having any tunneling or not. If there is a tunneling there, you have to give special attention on that area. Otherwise, that wound won't heal properly. Next is stage 4. The stage 4 is exposed muscle, bone, and tendon. Or muscle, bone, and tendon is involved. So there are a lot of necrotic. Sometimes there are a lot of necrotic tissues will be there. So I'll tell the management later. So fifth one is unstageable. The unstageable is if there is a black necrotic tissue. You can see that image. We can't assess, we can confirm the stage, because if there is a black necrotic tissue on the top of the skin, there we can't say this might third stage or fourth stage. So once we remove the top, the black necrotic tissue from the top of the wound, then we can able to tell how much that layer involvement is there. So it is involved up to subcutaneous level, or it is affected in the muscle, bone, and all. So these are the five stages. The first one is non-blanchable erythema. The second one is the dermis layer will be breakdown. The third one is full thickness ulcer. All subcutaneous tissues will be affecting. The fourth stage is muscle, bone, and tendon is affected. The fifth one is unstable. Next is assessment. So we all know that if you do the proper assessment, you can able to do the better planning, because based on your assessment you will plan. So if you do the assessment properly, definitely we can able to plan that clearly, and we can, if you make a clear plan, definitely the patients will get benefit, and we can able to improve the quality of the patient and the family too. So here, what are the things you can assess? Assess for pressure points. Even if the patient is on wheelchair, also you can assess. Assess pain. If they have pain, if they have a wound already there, definitely you can ask them for pain. If they have pain, you can give some analgesics for that, and then you can do the dressings. Assess location. Measure approximate width, length, and depth. Stages of wound. Presence of exudate. If there is exudate, means discharge, purulent discharge or clear discharge from the wound, and assess for tunneling and chart to find. So all those things you have to document it properly, because we need to do the follow-up later. So we need to check whether our treatment is good for the patients, or we need to, if the treatment, your drug is not benefit for that patients, you have to change the management plan also. And also that if you document it properly, definitely your colleagues will get benefited, because if they are going to see that patient again, they will get a good idea for that patient. And coming to the management part, as I said earlier, always try to medicate the patient pain before wound care. So if they have pain, you have to give some analgesics and make sure that the patient is having no pain, and then you can do the dressings. Stage 1. So the stage 1 is non-blanchable erythema. The management of stage 1 is you can prevent further pressure on that area. If you have noticed non-blanchable erythema in one side, you have to teach a caregiver to excellent turning techniques and incontinence control also. And coming to the stage 2, cleaning and dressings with normal saline. There is no pus, only clean wound is there. So normal saline is enough for cleaning the wound. Third, fourth, and unstageable wound management. If there is a slough, black necrotic tissue there, if possible, you can do the surgical debridement. Okay. Use normal saline for wound cleaning. We usually teach the patients about how homemade preparation of homemade saline. So I'll tell you later how to make a homemade saline. And if there is an odor or infection there, you can apply metronidazole powder. The same tab metronidazole, crush it and make it a powdered form, and mixed with the white petroleum jelly, and you can apply on the wound. Because nowadays the literature said moisture is one of the important part of wound healing. So what we do here is we usually mix with white petroleum jelly and apply on the wound. So that time the metronidazole will give a antibiotic effect to the patient, will control the maybe prevent the infection or control the infection, and the white petroleum jelly will give a moisturizing effect to the wound. And also you can use debridized ointment. If there is necrotic tissues like slough there, you can apply debridized ointment, but the thing is too expensive. If they are affordable, you can suggest for that. Once the necrotic tissues or the slough is removed, that removed from the wound, you can apply Metagil. So that will help to wound healing that faster. But the thing is, these two ointments are quite expensive. If they are affordable, you can suggest for that. And charcoal. So charcoal is one of the good agent for controlling bad smell. So you can easily make it in your home. Charcoal. This you can keep it in the room, one or two pieces, or under the bed of the patients. That will help to control the absorb the bad smell. And also charcoal dressings are available. This is also expensive. If they are affordable, you can suggest for that. And here we don't that suggest any hypochlorite solutions like povidone solution and hydrogen peroxide for cleaning the wound, because these solutions, they especially hydrogen peroxide and povidone solutions are hypochlorite solutions. These will destroy the granulation tissues. That is why we don't suggest these kind of that solutions for cleaning the wound. We use normal saline for cleaning the wound. And if the patient's health status is okay, then you can think about the surgery consultation and the skin grafting procedures. So you can refer the patient to the surgeon and see whether there is any skin grafting procedure is possible or not. And the last option is negative pressure wound therapy. So you can do the negative pressure wound therapy also. If you do the negative pressure wound therapy, so that will help to remove the exudate, the excess, the pull and discharge from the wound, and also it will give a continuous pressure. That because of that continuous that stimulation will improve the blood circulation, and that way we can able to improve the wound healing faster. So homemade saline preparation and dressing materials. So this is one of the important part, because we usually most of the palliative care settings will be issuing the dressing materials and the normal saline and all. But if the dressing materials are finished, what they can do? So how will they manage the wound? So you can just imagine the corona time. So the corona time, so we are not able to go for seeing the patients that because of the COVID-19 outbreak that time. So that time, what happened is we usually teach the caregivers about the dressing materials preparation and all. So they can use 500 of the, if they want to use make a homemade salad, they take 500 ml of water and add 1 teaspoon of salt, boil it, cool it, and keep it covered. That solution, so they can use for wound cleaning. So these kind of wounds are not the sterile wounds, it's a clean wound, no. So clean saline is enough for wound cleaning. Here, the another thing is dressing materials. So they can take a cotton sarees or dhotis and then cut into squares and steam them. So that also they can use for dressings. Because if the one important thing you have to tell the caregivers is, before and after touching the wound, they need to do the proper hand washing with soap and water, because after boiling, maybe after steaming the linens, cotton dhotis or sarees, so if they are not wash their hands fully, again it is infected, no. So better always you have to tell them to wash their hands with soap and water before and after touching the wound and dressing materials. And we all know that, but the prevention is better than cure. Here also, try to prevent. If you have seen a bedbound patient, definitely you can educate the patient about patient and the caregivers about how to prevent pressure ulcers. Okay, so the first one is position change. Every 2 to 3 hours, we need to change the position. Okay. And also, if the patient is on wheelchair, every 15 to 20 minutes, they need to relieve their pressure. And manage incontinence. If they have an incontinence there, you have to manage it properly, because moisture is another causes of pressure ulcer. If they are willing to put a catheter, you can put a Foley's catheter. Otherwise, they can, if they are affordable, they can use diapers. Or if they are not affordable, they can use their own linen. But the thing is, if there is any wet happen, definitely they need to change the sheets as soon as possible. Otherwise, that it can cause pressure ulcer. And you can suggest a special mattress like air mattress and water mattress. There is two different between air mattress and water mattress. Air mattress needs electricity and water mattress doesn't need any electricity. So here the air mattress is good one because there is a the alternate pressure exchange is also always there. And another the thing is, whenever you have suggest you this kind of mattress to the caregivers, or you can give to the patient for preventing pressure ulcer, you have to tell them this is not 100% measures, because if you don't tell anything, they might be thinking like, so this mattress will take care of everything. So again, if they are not able to turn the patient after putting that air mattress, definitely after 1 week, the patients will develop pressure ulcer. This is one of the important message you have to convey to the caregivers and the patient about using of air mattress or water mattress. And you can also advise to use pillows and cushions also under the bony prominence. As I mentioned earlier, nutrition, hydration, exercise. These are the another important factor, because nutrition, if they have a protein impairment in their diet, can cause pressure ulcer. That if they are not taking any fluids, dehydration there, definitely it can also affect the patient. And exercise, if you do the exercise, definitely that way we can able to improve the that blood circulation. That way we can able to prevent pressure ulcer. And massage. Whenever we turn the patient from one position to another position, you can take any moisturizing cream. So if there is a moisturizing creams are not available, they can use coconut oil and take, and you can give some massage. And you always you can give a special attention to the bony prominence. So after that, you can give a small massage on that dependent area, so that we can able to improve the blood circulation of that area and prevent pressure ulcer. And always you can provide a wrinkle-free bed, and nail care is also important. If they have a nails in their hand, definitely they will scratch their own skin, and that way the patients can develop pressure ulcer. So this is the small key. You can keep it in your mind whenever you have seen a bed-bound patient. Double SKIN. The first S is you have to think about the supporting surface. Whenever you have seen a bed-bound patients, always you have to think about the supporting surface. Make sure that your patients is get pressure relief on the proper supporting surface. Okay. And the next S is skin inspection. So whenever you have turned the patient from one position to another position, you have to give a special attention on the bony prominence, and you have to teach the caregivers about the importance of about the signs and symptoms of that major changes of the skin. Also, you have to at least they can see if there is a red color there. They can able to see it, and we can if they are able to see it on the first stage, initial stage, we can able to prevent further deterioration. And the K is keep moving. Every 2 to 3 hours we need to change the position. And the I is incontinence. So incontinence or moisture control is also important. Bladder and bowel care. So as I mentioned earlier, if they are willing to put a catheter, you can use Foley's catheter for draining of bladder. And here frequent the changing of diaper is also important. If they are affordable, you can suggest for that. And the last one is N, nutrition. Nutrition and hydration is also important. So these all this way we can able to prevent. These are the ways we can able to prevent pressure ulcer. So this will be doing when they go back to their home. The caregivers will do it alone, and we need to educate the caregivers, and we need to demonstrate the caregivers about the patient care. So how do we engage the patient and family for that patient care? So this is very, very important. We need to, without the family, the caregiver support, we can't do anything. So we need a full caregiver support for giving good care to the patient. So here you have to develop a contract with the patient, with the caregiver side, because even if you just imagine, we always use the term you should do like that, you should turn the patients, you should apply massage, you should give like that, you should give proper food, you always we used to use the word you. Instead of you can use the term we. So if we use the term we, so they are also feeling like somebody is behind them to help them. That also will be there. So you can start to use the word we. So we can see what we can do together. That kind of things will help a lot. And also you can provide that patient information leaflets also. So you can, this is a Malayalam version. If you can do it in the your own language also, this will help to the patients, the caregivers, for that maybe if they have any mistake can happen, maybe sometimes they forgot to what that you taught you during the home visit. If they have any doubts, they can go there and look into that leaflets if they have this kind of leaflets are available. So we have a small video. So we'll show you that video, and then we'll learn about the fungating home. Thank you.
Easier to prevent than to treat. Mr. Sanal Kumar, aged 35 years, is bedbound after a recent accident. Anita is his wife and caregiver. He is being visited by nurse Sumi at his home. Good morning, Anita.
Good morning, sister.
Good morning, Sanal. How are you?
Good morning, sister. I'm doing fine.
Good.
Sister, I want to ask you something. I've heard that people who lie long hours on the bed develop bed sores. I change his position 2 to 3 times a day. Is that enough?
That is not enough, Anita. I shall show you the ways to prevent bed sores.
Okay, sister.
It is very important to change the position every 2 hours to ensure proper blood circulation. If patient has been lying on his back for 2 hours, turn him to one side for 2 hours. Remember to put small pillows between the bony points of the knees, elbows and ankles to prevent pressure on the skin. You can also use folded sheets instead of small pillows. Inspect all the pressure points with a torch. This is very important to detect formation of bed sore early. In a bedbound patient lying more on his back, inspect back of the head, shoulders, elbow, sacrum and heel. If a patient is lying more on one side, inspect ear, shoulder, hip, inner sides of knees and ankle. If there is any color change in the skin, avoid pressure and moisture on those areas. Using oil or lubricant, massage the patient's back with both hands in circular motion, stroke upward from buttocks to shoulders. This will help to improve blood circulation, preventing skin dryness and cracking. Turn him on his back after 2 hours. Then let the patient rest in supine position for another 2 hours. Again, turn the patient in other direction and maintain the position for 2 hours. Repeat this cycle and continue perform massaging and inspection. It is good to use airbed or waterbed as supporting devices to prevent bed sore. Do not make the patient lie directly on the airbed or waterbed. Always use a cotton bedsheet over the airbed or waterbed. If wrinkles are present on bed sheets, the skin rubbing over the wrinkled sheets may cause friction leading to bed sore. So, always provide a wrinkle-free bed. In case bed becomes wet, change the sheet as soon as possible. Keep the bedsheet dry always. If there is urinary incontinence, place a urinary catheter. Nails should be kept short. Otherwise, scratching can cause damage to the skin. Never drag or pull on a bedbound patient. If needed, patient can be lifted with the sheets. Healthy diet is important in preventing skin breakdown. Encourage the patient to take protein-rich foods like egg albumin, pulses, and groundnut. Drinking adequate fluids is important to maintain hydration of the skin. Patients using wheelchair should be made to lift their buttocks every 20 minutes. Use cushions for sitting on wheelchair. Inspect shoulder, buttocks, heel and ball of the foot. Hope you have understood everything.
Yes, sister.
Thank you. So I hope that bed sore part is clear to everyone. So then I'm going to move on to another session. Another topic is fungating wound. So before that, I would like to ask one question. So what is the difference between the pressure sore and the cancer wounds? So either you can unmute yourself and talk, or you can put your answers in the chat box.
Pressure sore is caused due to the pressure, where the oxygen is not being properly supplied to the blood, and that is how the wound comes. Cancer is there is a cause for that, and it is a non-healing wound. Cancer, you cannot do dressing or anything like shifting the bed, everything cannot heal it, and it has to be treated properly with the chemotherapy or whatever it is, an excision ought to be done, and following that dressing can be done accordingly.
Okay, thank you, sir. Thank you, sir. Any other points? Anybody want to share?
Pressure sore areas will be involved in pressure wounds most
Okay.
commonly.
Okay.
Whereas
Thank you,
in
ma'am.
cancer, and then foul smelling more common in fungating wound and pressure wounds.
Okay, thank you. Any other points?
Fungating wound can be treated with antifungal.
Okay. Okay, thank you. So here, as all of you have mentioned earlier, this is a non-healing ulcer. The major difference between pressure ulcer and the cancer wound is pressure ulcer is preventable and curable. This is not preventable and not curable. So once the wound is developed, we are not able to cure properly. It's a non-healing ulcer. It is a primary or secondary malignant growth in the skin, which is ulcerated and difficult to heal. So the same time, involvement of both ulceration and proliferative growth will be there. Because of that, lot of necrotic tissues will be there, and lot of exudate. There are a lot of signs and symptoms will be there, and it looks like a cauliflower in shape and nodular fungus shapes. Not because of that, because of the nodular fungus shape, we call this kind of wounds is fungating wound, not because of fungus. Okay, so this is the cancer wound. It looks like the cauliflower in shape or a nodular fungus shape. Let's see the pathophysiology. See, we all know that development of non-tender skin nodules. So gradually what happened, the skin nodules will enlarge. So if there is a nodule enlargement there, definitely that will affect the capillaries and lymph vessels. For that, then that leads to altered coagulation and disorganized circulation. finally tissue hypoxia and necrosis. This is the pathophysiology of cancer wound. So have you heard about Marjolin ulcer? Anybody? Okay. So this is a type of malignancy of the skin. Malignant changes in a chronic wound. Okay. So example. Okay. Thank you, sir. Barn scar ulcer, pressure ulcer, venous leg ulcer. So these are the some chronic wounds. So sometimes these wounds can change to the malignancy. So the pathophysiology is little bit different. Appearance of mass in the wound, not previously present, is like a granulation tissues. So onset of pain, not previously present. The same thing. So the patient is, when you touch that part, the patient will say like, I'm having pain. So, and also the change in character, volume, appearance, or the drainage and all. So that patient says like, so a lot of the oozing coming out since last 2 to 3 days. That kind of the symptoms the changes will be there. So if you see these kind of changes in a chronic wound, better you can send the patient to the oncologist and take a biopsy and find out whether the wound is Marjolin ulcer, developed any Marjolin ulcer or not. If there is a Marjolin ulcer there is a possibility, a curative possibility cancer, better you can do the proper management. And coming to the problems. So from the initial days also beginning, also you have learned about palliative care. So palliative care is a total care. We need a total care to the patient and their family, because this is a non-healing ulcer. This patient need continuous attention, total care also. So there are a lot of problems will be there. Let's see one by one. Physical problems, pain. Here, so if they have developed a tumor in one area, definitely the tumor will be proliferating, right? So the tumor, the cells will be compressing, that maybe distressing the nerves or blood vessels. That time the patients will may be experience neuropathic pain, and also the direct exposure of dermis can cause nociceptive pain. So these kind of pain, the different types of pains will be there. So when we do the assessment part, you have to assess it properly, whether if they have said like, I have pain, like that, you can assess properly whether they have a neuropathic pain or nociceptive pain. And another thing is malodor. Here, lot of necrotic tissues, proliferation will be there, and because of the anaerobic bacterial infection, foul smell will be there, and another thing is, another cause is stale exudate dressings is have been more than number of days, can cause another cause of malodor. So again, you can think about that also. Bleeding. So sometimes the tumor will be protruding the major blood vessels. So that time also, that is one of the palliative care emergencies. If they have a head and neck cancers, if they that kind of that emergencies there, so you have to prepare the patient family about that part, because they need to, if they happen in their home, so they need to manage well. So we need to prepare the patient family, and also improper dressing techniques. So usually the dressings are adherence to the wound. So because before soaking the wound, soaking the all dressings, try to remove it. Then the patients can experience pain and bleeding. So better you can soak the wound before removing the before that. Then you can after soaking the wound, you can able to remove it properly, and they won't feel any pain and bleeding. And coming to the next one is exudate. There are a lot of exudate coming out because of the blood inside the wound. There is vasodilatation will be there. Because of that, the tissues, the fluids will be coming out, the purulent discharge will be coming out, itching will be there because the new nodules will be emerged the sides from the sides of the tumor. So because of the chemical reactions, the patients will feel like itching, and also the exudates will touching the normal tissues, that can also the patients can feel itch. And infestation with maggots sometimes happen, and communication difficulties, especially head and neck cancers. There they are not able to communicate their problems clearly. So what you can do is, if they are able to write down their problems, you can give a sheet of paper and ask them to write down their problems. So if they are able to write down, we can see that problems and the paper, and based on that we can able to treat the patient fully. And coming to the psychological part, just imagine the patient is having a buccal mucosa cancer or a CHE. There are a lot of altered body images will be there, no? Even if you have developed a small pimple in our face, if we get a chance to see a mirror, so in front of mirror, so we have seen check whether my that pimple is bigger than yesterday, or whether there is any mark after that, if there is any black mark will be there, on that kind of tensions inside our mind always, even if a pimple. So just imagine that big ulcer on the face. So there definitely it will be affecting the patient psychologically, and sexuality will be affecting. Denial, sometimes positive denial will be there, and sometimes negative denial will be there. So even if the patient knows the truth, if that this kind of wounds are not healing, not going to heal properly, even then they will be asking like, my wound is healing or not. That kind of questions will be there. They like fear will be there, depression, anxiety. They will be anxious about what is happened to be next. That kind of things will be there, and finally sometimes goes to depression, to shame, guilty feeling. These kind of things will be there. So coming to the social part, family isolation. So if a person can develop this kind of ulcer in a family, the family members also choose a corner side room and keep the patient there. So they won't allow the patients get out from the room. So these kind of problems affecting the patients emotionally and socially, and even spiritually also. Social isolation will be there because nobody is willing to visit these kind of patients because of misconception of disease. Sometimes before getting this kind of problems, there are a lot of friends will be there, but after that nobody is willing to visit these patients, but because of maybe misconception or fear or something like that. So this will be affecting the patient emotionally, and social stigma will be there, affects on family, and also it will affect the sexual relationship and marital disharmony also, because nobody is willing to get marriage of this kind of family because of maybe hereditary factor and all. So these all things will affect the patient emotionally, because of me only my daughter is not getting married. These kind of questions always inside their mind. And also coming if you see the spiritual part, they might be thinking like this, there maybe interference with the religious, right? Because of my sin that God punished me like that. That kind of things will be there. So what you can do is, if possible, you can do the individual assessment. Okay, in front of the caregivers, they don't tell the truth. So this is very, very important. In front of the caregivers, if you ask something for the wound care or anything, they will be telling like, oh, she will take care of everything, he will take care of everything. So if you do the individual assessment, they will tell the truth. So nobody is willing to touch me. That kind of answers will coming up. And come to the assessment part, you can assess the own location, because if there is easily mobility impaired and we can able to easily covered with a public view, because this is also important. I have a patient. He used to take bring a big towel with him always. So after the dressing, I was asking him about, so why do you bring this long towel with you always? Then he told me like that, this is my safety. I said, why? What do you do? So after dressing, so what he usually do is he used to take a big towel and cover the whole the head. And because after what he told me is, he said, if we after dressing, if I get out from the hospital, if I have a dressings in my face, everybody is seeing me and asking me what happened, what is happening in your face, what. And also if he is traveling by bus, nobody is willing to sit near to him also. That is also affecting the patient psychologically. If he cover it properly, no problems. I can travel safely. I can travel happily also. Nobody can see my area that wound. So that kind of thing. So these are also important. When you do the assessment part, you can do the assessment of these things also. Wound appearance, surrounding skin, potential for complications. If there is a head and neck cancers there, you have to prepare the family members too. Coming to the principles of management, palliation of symptoms. Try to reduce the pain. So if you do the proper management, like if you reduce the signs and symptoms of the patients, definitely we can able to improve the quality of life of the patient. So always try to reduce the signs and symptoms. Like if they have pain there, you can try to reduce the pain. If they have an odor or infection there, you can try to control their infection. If they have an exudate like oozing or purulent discharge there, you can try to reduce the exudate, minimize bleeding, and holistic care. This is holistic care is a total care. So this total care is needed for this patient. Always try to empower the patient and family for wound care. Criteria for wound care is our goal of care is to improve the quality of life. Okay, so always this patient need an empathetic care, and if they are able to take a thorough bath, you can ask them to take a thorough bath, because these kind of wounds are fragile. So without applying your forceps, if they are able to take a bath, all necrotic tissues will fall off. So after that, you can do one thing. You can wash with normal saline and apply metronidazole and keep the wound, cover it properly. And also here also you have to make sure that the patient is having no pain. If they have pain, you can give some analgesics before that. And during the pain sessions, you have learned about nociceptive pain and neuropathic pain. Here also, if there is a nociceptive pain there, like deep pain there, your systemic analgesics will help. Okay, so for example, if they have a morphine, or having morphine, you can in between, if they have developed pain, breakthrough pain there, you can give an additional dose, and that way we can able to manage. But if they have a neuropathic pain there, like a superficial pain there, your systemic analgesics may not work well. So that time you can apply local anesthetic agent like sensocaine or xylocaine to the wound. So after 2 to 10 minutes, the patient will get a local anesthetic agent effect. Then you can do the dressings. Then malodor management. Here, lot of necrotic tissues will be there. Foul smell, lot of foul smell will be there because of the anaerobic bacterial infection. You can same way you can clean with normal saline and apply metronidazole powder. Okay, and there is a lot of pocket formation inside the wound. So that time your metronidazole powder now goes inside. Better you can use injection metronidazole cleaning the wound. So that time the injection metronidazole will go inside the pocket formation, pocket areas, and that way we can able to prevent control infection. And if they have, and also you can suggest the charcoal dressings also, and or you can put the charcoal pieces in the corner of the room or keep under the bed of the patient. That will help to absorb the bad smell. And also you can think about the course of antibiotics. So superficial blood supply is not good for these type of patients, but you can help. You can try one course of antibiotics. And frequency, the changes of dressings, the frequency of dressing changes based on the wound size and symptoms. Like if they have a lot of exudate there, maybe the frequency of changes, the dressing changes will be increased. And here also no hydrogen peroxide and betadine. So this will not help this kind of wounds, because this will irritate if you use this kind of hypochlorite solution to the wound. This will irritate the tissues, and again, if there is any irritation there, the patients will develop experience pain too. So it will not help anymore. So you can use normal for wound cleaning. And also the drug of choice of controlling anaerobic bacterial infection is metronidazole. You can apply systemic, you can apply topically, and if the malodor is not controlled, then you can use systemically also. Then bleeding, always try to prevent. If there is any dressing adherence to the wound, so you can soak the dressings with normal saline or a normal water, and then you can remove it. That way we can able to prevent bleeding. If they have bleeding there, the wound has bleeding there, apply local pressure. So, and then you can apply sucralfate powder as the same drug which we have used for peptic ulcer patients. So the same drug will help to control the bleeding. And again, you can apply tranexamic acid. Then if that is not help, then you can go for a systemic at arm's length, and then palliative radiotherapy also. Then the important message you have to convey with the caregiver is the use of dark color cloth. If there is any bleeding happen, maybe profuse bleeding happen, what they will do and how will they manage, that important message you have to convey to the caregivers, and you have to prepare the caregivers clearly. Because if they wipe the blood, if there is any bleeding happen, if they wipe the blood with a white color cloth, what happened? So they will be anxious and panic and all. So that will affect the patient and the other relatives emotionally, and they will become panic also. So if they are using dark color cloth, that panic, shock and anxiety will reduce. So role of cancer therapy, radiotherapy, cytotoxic chemotherapy, hormone therapy, and surgery. Surgery is debulking surgery is also there. So if the patient's health status is okay, then you can think about that. And radiotherapy, cytotoxic chemotherapy, hormone therapy. So if you do this, the treatment is that will help to strengthen the size of the tumor. So that will help to prevent bleeding for a while, because if you do these kind of therapies, that will help to strengthen the tumor. So that way we can able to prevent bleeding for at least 3 to 6 months. After that, also that tumor will growing up. Next one is maggots. How does maggots come? How does maggots come? Anybody? How does maggots come? So I am waiting for your answers. Lack of sensation and non-cleaning of wounds, Sheena ma'am said. Any other answers?
Flies will lay eggs on the wound, and that would cause
tissue anoxia. Okay, ma'am. Thank you. Thank you for your answers. So here the maggots are come from house flies. So usually the house flies are attracted with the infected wounds. When they touch the wound, they may lay eggs. Okay, within 8 to 12 hours come out of maggots. So that is why we educate the patient and the caregivers about the importance of covering in the wound properly. Okay, so if they are not knowing this, so they used to do open the wound always, and then that house flies will touch the wound and may lay the eggs, and after that, if they are not do the dressings properly, definitely come out of maggots. So if there is a maggots there, do one thing, you can take a turpentine and soak the turpentine with a gauze piece and keep close to the wound. That time the maggots will come out. The physical removal is the only way to remove the maggots. Okay, and another important message I want to convey with you all is don't follow maggots. If you follow maggots, what happened? Your artery fossa, there are a lot of pocket formation inside. When you go with your artery fossas, usually the maggots go inside. So if you follow maggots, what happened? Your artery fossas will rupture the blood vessels. The maggots will keep safe inside. So don't follow maggots. When they come out, you can take it out. Otherwise, you can leave. So within 10 minutes, they will come out. So keep them. You can use turpentine for removing the maggots. Thank you. Any questions?
Is there any role of honey for the pressure sore? One, and nowadays they give oxygen therapy. Does it help? And metronidazole has been proved to be carcinogenic in animals. So how does it help out? We have to be precaution use for a certain period, for a short period, or we can be using it till it heals for on long term also.
Okay. Thank you, sir. Anybody want to answer this question? Sir was asking about the honey usage or
Pressure sore.
anybody have any experience? So I don't have any experience, sir. But the literature said honey and sugar paste will help to heal the wound, because of that will that will decrease, maybe that bacterial growth will be prevent. If you apply honey, that will prevent the bacterial growth. That way we can able to heal properly. That was I read up one article. So I don't have any experience, personal experience, and hospital here palliative care experience for using honey. And the next question is that metronidazole, right?
Oxygen
Sir?
therapy.
Oxygen therapy also.
Oxygen therapy.
So I don't have any experience. Anybody have any experience on oxygen therapy?
Generally, see, I too don't have any personal experience on oxygen therapy, but generally oxygen therapy improves this mitochondrial exchange and oxygen thing. So with oxygen therapy, there is a very fine line that can become detrimental too. So I would say it has to be used with a great amount of caution, but I don't have any exact experience. But the main thing to be borne in mind is that you can't just use it just like that, because it's only a fine line. It can become dangerous. So, and especially when you allow people to use, even when we allow people on home oxygen things, we can see with oxygen therapy and things, you may be very careful. Someone may smoke somewhere nearby. It is more harmful and dangerous. So The thing is that with great amount of experience, education, only then oxygen therapy could be used, and cost is another thing to be kept in mind. So I don't have any personal experience, but advising and prescribing, these are things which we generally follow.
So Dr. Nuki said an Ayurveda is used for Grina Rohana. So can you please explain a little more about that?
Usage of metronidazole on long term.
Yeah. So metronidazole, there is no issue for using long term. Then there is nothing. So I have more than 20 years of experience in palliative care, but I don't have seen any problem at all. So I don't know.
Can use it.
Same, Sheeba. I was also about to tell the same thing regarding metronidazole. I have used it for a very, very long time. I worked in my involvement in palliative care has been from 2017. But before that itself, I have used for general wound care and healing, and metronidazole, powdered metronidazole. I know, like the label comes that it is carcinogenic, okay, but it has been used a lot, and then so maybe, doctor, I will have a look. I will look into the literature and see if there is anything more to that. So it might be of good help to all of us. So that alone, I will have a look. Before our next session, I will have a look and see if I could get any more information. But as she has mentioned, and I have also used it for a very, very long time, and the benefits are more, especially with palliative care. It is cheap, effective, and I have used and advised patients, and they use it and come back with better response.
Okay.
And all what she said, this homemade dressing, I have recommended that, and everyone has a pressure cooker at home. You teach them how to do it. So for dressing with that homemade dressing material and the metronidazole, I have seen good results with it. So the specific ill effect or the carcinogenic impact alone, I will have a look and see if there's anything in the literature available. Apart from that, it has been useful. What was the other thing? And what was mentioned in the chat, I just was about Dr. Ruhi. What is that? It's mentioned Grina Rohana. What do they mean by that?
Yeah, so here at our center, we have multiple departments working together for example, physiotherapy, allopathy, and Ayurveda. So I'm sure I'm not very correct with the term. I'm not sure it's Griha Rohan or Ropana, but there is.
Okay, you tell, then I will tell you whether it is Rohana or Ropana.
Ropana, because so I do have multiple meetings with the Ayurveda doctors also. So in terms of using honey, they have been discussing. I'm not sure if they have. I'm not sure myself about the outcomes per se, but I have had discussions with them where honey with neem or honey with turmeric they have used for dressing because of its antibacterial property. So I have come across this form of dressing, but not that it has ever been done at our center.
What do they exactly do? You just tell, and then from that I'll try to see what I can help.
Like I said, ma'am, I'm not very sure the correct procedure, because in that department, we do have certain wound management where Ayurveda is also taking care of some patients for the wound management. So we had this one case with a diabetic foot, wherein the family, when they had come in, they wanted to only go with Ayurveda and they did not want allopathy dressing or allopathy in terms of management. So they had this mixture made with, I'm not sure if it was honey alone, but they did do the dressing with some Ayurveda. I'm not sure what exactly, but yes, in Ayurveda, they used something, and I think honey was a part of it. So they will just cleanse it, and they will apply this and keep it wrapped with one of the cloth. So they'll be cleaning the wound and they'll be wrapping with this concoction that they are making.
See, the ropana, this is little bit, no, when they apply, it will have a different term. That like it could have, because of Ayurveda, it will have Sanskrit element. That whether it is application or what will have a different name to it. That's all. So I just in your
it has got an antioxidant, antibacterial, and anti-inflammatory property. The honey is a biological wound dressing, actually.
Exactly. Ropana means to apply.
Yeah.
So ropana. That's
We don't have much studies about that, but people have been using from olden days. Yeah.
Exactly. See, as you said, no, we always say to patients also, no harm. If you want to follow something, which is that may not
but I
have
don't think
big
it
deal
helps in a larger wound. Maybe for a smaller wound we can try.
Correct.
Not for the big wounds. Maybe when it is a stage 4 or stage 3, I don't think it will help.
Exactly. See, all these, no, you can use in the initial stages because where the benefit may be better, and especially in some phases of patients, no, when they are really in a situation where, oh, I will try something that will help me. So
Correct.
when you are in that situation, they would love to try. So that's why I am happy that Dr. Ruhi, as she said, no, she's got the exposure to have the opportunity to try naturotherapy or other modes, alternative medicine, as we say. Everyone tries. The most educated also try that. Don't think that it is only, so everyone, because it's that phase of life you are in, because you are in a stage, I don't want to leave anything that I've not tried. Let me try and see what best I can get out of it. So like that, you have to see where the benefit there. Is that benefiting the patient, or is it going to a stage where it is harming the patient, or where it is in a stage where there's no benefit obtained? So there again, assessment, reassessment is what will help. Good. That's what. See, these are other options which has been tried and tested to see if it could be of a help in any form. Anything else is there in the chat? Yes. Please go for the case. We get engrossed with the discussion. We are sorry about it.
Good evening, everyone. I'll be presenting case of, I hope I'm audible.
Yes, you are.
Yes, you are audible.
I'll be presenting case of a 34-year-old female with diagnosis of left buccal mucosa. The staging, we couldn't get the exact report, so it's T4 and nodes are not known. The presenting complaints were pain at the jaw and neck, malodor, dribbling saliva, and difficulty in chewing. History of presenting illness, the patient was apparently well 1 year back when she started noticing swelling on the left side of her jaw, which increased in size over time and later got injured while brushing, leading to formation of an unhealing wound at the local site, which grew in size over time. The patient received local treatment for almost 9 to 10 months and was later referred to higher center in view of suspected malignancy. The patient was offered options of surgery with radiation therapy, and due to financial issues, the patient only opted for wide local excision and did not follow up for radiotherapy. The patient was not on any kind of treatment for a very short duration of time due to lack of support from family. The patient was offered free dressings at our hospital and was given medications for pain management as well. And by that time, the wound has already involved the nerve, so there was formation of corneal ulcer, which was again offered, but we lost the patient to follow up. The patient was referred to a regional cancer center nearby and has been receiving treatment from the same place since then. And recently, a punch biopsy has confirmed the diagnosis of invasive keratinizing squamous cell carcinoma. On examination, the patient is thin-built, conscious and oriented. The vitals were blood pressure of 180, heart rate was 96 per minute. Afebrile, the saturation was 98% in room air. Lag of thalamus on the left eye with exposure keratopathy leading to pseudocorneal formation. Pallor was present, icterus absent. Lymph nodes were subcentimetric, and the chest was bilaterally clear. Treatment, recent blood investigations, the hemoglobin levels were 8.6, and it showed the microcytic hypochromic picture. Other parameters were within normal limits. Iron sucrose injections were given for the same. Punch biopsy, as I had earlier mentioned, it confirmed the diagnosis of invasive squamous cell carcinoma. Daily dressings were done, and the patient was taught for the same. It was done with normal saline, and the patient was told to use salt water at home. The patient has also been offered NG tube insertion, which she denied. The patient was given antibiotic eye drops and was planned for tarsography, but she didn't show up for it and was not willing for it. Psychosocial aspect, she has 4 kids, 2 of which were married before the age of 18 in the fear of death because she was not keeping well. The husband is an alcoholic, and he pays no regards for the well-being of the family. He hasn't been supporting the family financially too. The patient is unable to eat food without falling it off her mouth, which makes it difficult for her to attend any kind of social gatherings. She's basically on a semi-solid liquid diet. The patient has absolutely no financial aid following losing her job as housemaid, and this has led to her begging from the streets. Medications, this geftinib, morphine, Rantac, Bicosol, and doxycycline has been started from the nearby regional cancer center, as our setup doesn't have narcotic licenses. A tablet of tramadol and paracetamol and metronidazole dressings were done from our end. Main concern, the patient has been lost for follow-ups frequently, indicating that there is lack of motivation to seek treatment, lack of support from the family. She has body image issues, fear of death, inability to participate in the society, loss of self-respect, lack of community outreach also from our end, since we ourselves are not able to stay attached with the patient. Summary, 34-year-old female with invasive keratinizing squamous cell carcinoma of left buccal mucosa, still under evaluation. Discussion points would be body image issues, lack of financial support, and the malodor surrounding her. Thank you.
Thank you very much, dear. You brought something which was very appropriate to our discussion main topic today. And from your main discussion points, I would say malodor surrounding her has been dealt in great detail in our by our faculty today. And especially the charcoal, what is mentioned, is something very simple thing to be done, which could be taught to the patient and the family, so that would be helpful to them. And all the other things what has been mentioned, oral care, everything is important. Even for oral care, giving them some suggestions that they could use and make it at home is something very, very important, which will deal with the financial restraint also. Okay, so with the rest, like body image and financial support, I'm going to leave it open to everyone to see what is that they would all like to come up, and then we'll go back to Sheeba also. Yes, somebody has mentioned about banana leaf to avoid pressure so in the bumps. Like either you, all of you can unmute and talk or type in the chat.
So we would like to hear from you all. So if you have seen these kind of patients in your settings, how will you manage? So we need to help to Dr. Ria. So your suggestions and comments will helpful for her. So please unmute yourself and talk, or you can put your answers in the chat box. So before that, I would like to ask one question to Dr. Ria, sorry. Can you please forward that move on that medication part. Yes. So here, is there any modification needed? Anybody want to? Yes. Anybody want to modify this prescription? Okay, Sheena, doctor said add bisagodil. Okay, then antiemetics and laxatives. Okay, very good. Any other points? So your opioid session is over. So I am waiting. So here there is a weak opioid and a strong opioid is together, no? Tramadol and morphine.
Ma'am, actually,
Exactly. I
tramadol,
was also waiting for someone to say that.
ma'am, tramadol and paracetamol, when she was following up with us, is when we continued from our end. Since she has been going to the regional cancer center, from there she's only been getting morphine. So at present, tramadol and paracetamol is not being given to her.
Tramadol and paracetamol is not there.
Okay.
No.
Okay,
Okay.
very good.
Thank
So,
you.
so here you can
Still,
only
still we'll wait, Sheeba. If they find they can add one more. What is that they would
Patch.
like she can take like the patch is another alternative when she can't eat. What is that when you've gone through pain? What is that you can add on?
Methadone.
No, like what? Like we
Ma'am, antidepressants, laxatives,
yes,
and
adjuvants.
Paranol.
Adjuvants. Any adjuvant will help her a little bit with her anxiety, pain, sleep. So adding on an adjuvant will help her with other factors and the pain relief also. Very good. Sheeba was about to say something. Go ahead, Sheeba.
no, ma'am. So we can, not combine the weak opioid and strong opioid together, and always think about the laxatives. And,
Exactly.
So that is also important. You all already know that one of the most common side effect of morphine is constipation. So you have to give strong stimulant laxatives, especially not laxatives, stimulant laxatives. You have to prescribe and encourage the patient to take it properly. And also, as ma'am said, that you can think about the adjuvants analgesics also.
As I told the other day, no, if you're prescribing morphine and not prescribing laxative, it's a crime. I don't think, but I would say it is because you know it will cause constipation. So if you don't do it, okay, I will rephrase my word. It's negligence, okay? Because if you don't give something to what constipation is the very well-known side effect which is going to happen. And if you don't give something for that, you have to prescribe and explain to them how to take, then increase their water intake. And if they're not having any benefit, to increase it, decrease it, titration, all that has to be told, because that is something many people may find it very, very bothering to them. So please, whenever you prescribe morphine, add the laxative without fail.
So the next the discussion point is lack of financial support. So the first discussion point is body image issue. So that we were discussing through the presentation time. So I was discussing about that. The body, if there is a disfigurement there, definitely it will be affecting the patient emotionally, the spiritually and socially. So better you can do the individual assessment and listen her problems and explore her emotions. Okay, so once she is able to explore her emotions, definitely she feels some kind of relief, mental relief. So if possible, you could do for an individual assessment for this patient. And lack of financial support, how will you manage?
Ma'am, connect her to so NGOs, nearby NGOs.
Very good.
Most important, her problem is financial problems because she started begging. That means she has nothing. So most important, if you take care of her, that part, rest will follow. So she can be connected to all the government health, the social service schemes and everything available in the village. Even some nutrition schemes and for her, and because she has nobody. So such things the hospital can do actually.
So did she receive the cancer pension, Dr. Ria?
Ma'am, I'm unsure of it.
Oh. So you can think about that also. Okay, and also you can connect the NGOs, and if that financially is not well, her husband is also alcoholic, he's not supportive, and you can think about the food kits, food supplies also. If the no money is not there, so no food, so you can think about the food kit and vocational rehabilitation too also.
Okay, ma'am. Thank you.
Sheeba, this cancer pension, what is that? Just if you could give us a quick
Yeah, ma'am,
overview of that. I thought that would be helpful to one and all, or is everyone aware of it?
yeah, so cancer pension, that the Prime Minister will be giving the small amount of pension, that 1,000 rupees per month that cancer patients will get. I will share the form to Sri Priya later. She will share it in the WhatsApp group so that everybody can see it.
Thank you, Sheeba. That will be helpful because I thought something helpful for one and all. So they can at least make this awareness to people who are not aware. 1,000 rupees per month is a big deal. At least some proper meal, one meal a day, they'll be able to get. This girl lady can stop begging, even if she gets the 1,000 per month. Thank you. Anything else?
So I think most of the points discussed and about you can always think about the patient side. There are a lot of problems, pain, malodor. This will be affecting the family members too. Because if there is a malodor there, nobody is willing to sit near to her and nobody is sitting to her room. That will be affecting the patient emotionally. Try to control the malodor first and give metronidazole is very cheap, and encourage the patient to use metronidazole topically. If it is not help, you can advise to take orally. So that will help to control the malodor. So that way we can able to control malodor. And the another option is the charcoal. So that is they can make it in their home itself. Okay, so that will help to reduce the foul smell. And financial things, definitely you can connect with the NGOs and other groups. Maybe in the hospital also you can think about the charity things and all. So if possible, you can do the fundraising thing, and you can help the patient. And food kit also, if possible, you can provide a food kit for this patient, and because her family is her husband is not at all good here as alcoholic and not helping these patients. That also will affect the patients emotionally, spiritually, and psychologically. So always you can think about the total care. physical, emotional, social, spiritual. Okay. Thank you.
That's all. Like as Shiva has said, we have covered the topic, and with the case discussion also, we have dealt in detail. Really big thank you to you, Shiva, for going in detail, and all these what was told today, mainly the home remedies. And see, even the dressing and things, it is equally good. Don't have an opinion that is not good. You use your pressure cooker as an autoclave. Okay, so teach them and let them benefit, and then healing and things do happen. And we, as she mentioned, we have all had personal experience seeing the benefit. So please follow and help the public also. Thank you one and all, and a big thank you to you, Sheeba.
Thank you, ma'am. Thank you all. Thank you.
Thank you, ma'am.
Thank you, Sister Sheeba, for joining us. I have been personally seeing her having a very busy day, and still you managed to find out time and join us for the evening. Thank you so much for that. And thank you everyone for joining and making this session interactive. And with the promise that we will see you again with another important and interesting session on coming Monday with an eminent faculty. This is Sri Priya, along with Dr. Radha Venkatesan and Sister Sheeba Aris, signing off from the Tipsico Hub. Till we see you in the next session, everyone take care. Bye-bye.
Thank you.